Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can find our previous episodes on Apple Podcast, Spotify, Google Podcast, and on your favorite podcast app. Pseudogout, pseudo-RA, acute CPPD, Crown-Dens syndrome, chondrocalcinosis. If you're like me, these words may have caused your blood pressure to rise. But don't worry, I've got the perfect medication for you. Just listen to today's episode of ACR On Air. Our discussions will feature everything you've ever wanted to know about calcium pyrophosphate deposition disease, or CPPD. We're talking about the basics, using arthrocentesis and various imaging studies for diagnosis, creating classification criteria for CPPD, treating both the acute and chronic manifestations of CPPD, as well as all the questions that still remain unanswered. Just like our gout episode that we featured recently, this episode was long overdue. CPPD is one of the most common inflammatory arthritis in the world, and yet it probably doesn't get the recognition it deserves. Fortunately, I think that its time has come, largely thanks to our guest today. Dr. Sarah Tedeschi is a rheumatologist and clinical investigator at Brigham and Women's Hospital and assistant professor of medicine at Harvard Medical School. She received her medical degree from Vanderbilt University School of Medicine and completed her internal medicine residency and rheumatology fellowship training at the Brigham and Women's Hospital, where she currently serves as the head of crystalline arthritis diseases and is also the rheumatology director of the Giant Cell Arteritis Fast Track Clinic. She receives grant support from NIH NIAMS to study CPPD epidemiology and imaging. Dr. Tedeschi serves on the ACR Committee on Quality of Care, the ACR EULAR CPPD Classification Criteria Steering Committee, and is the section editor for Current Opinion in Rheumatology, Crystal Deposition Diseases. Enjoy the show. Sarah, welcome to the show.
Hi, John. It's good to be here.
So I gotta say, there's a lot of sexy topics in rheumatology these days. I mean, people are treating lupus with novel medicines. Vasculitis is also getting these novel medicines that seem to be steroid sparing. Even autoinflammatory diseases are now seeing their day. How did you become interested in CPPD of all things?
Yeah, CPPD has not been in the limelight for a while, and I am hoping that some of the research initiatives that are ongoing are going to make it more exciting and more interesting because it's really common. So the way I got interested in CPPD was during fellowship. I was on the consult service and there was a patient who was admitted with, I think it was his second episode of acute monoarthritis in a few weeks period. And he had joint aspiration both times, and it was incredibly inflammatory. And there were just a very few CPP crystals that were seen. And initially the thought was that he had septic arthritis and, he got treated with antibiotics. And then during his second admission, when I saw him, then, sort of the attention sort of shifted to maybe the CPPD was driving the whole thing. Well, I became his rheumatologist when he left the hospital, and he was one of the most frequent flyers to my clinic in the next couple of months. Really had, even to this day, probably had the most severe case of, there's so many different terms we could use here, but let's say recurrent pseudogout or recurrent acute CPP arthritis is the new term. He also had Crown-Dens syndrome during this time. We already knew he had CPPD at the time. So he actually was spared a lumbar puncture because I felt so confident that after like his 6th episode of acute CPP arthritis, and he came in with like neck pain, couldn't move his neck and had high ESR and CRP. We got the imaging, his CT scan was consistent. And he just ended up on a lot of steroids over that time. He also had myelodysplastic syndrome, which was, one question is whether, pathophysiologically, was that potentially related? I don't know. We wrote a case report about that. We wanted to give him anakinra. And then because of his myelodysplastic syndrome, he didn't want to take it actually. And then he ended up dying of sepsis, I think because of, all these steroids and, also had cytopenias from the MDS. And so as I was taking care of this patient, I started looking to the literature to understand what is there out there that we can do to treat this patient, especially with his comorbidities, and what's the state of our knowledge about this disease. And I was just struck with the lack of knowledge. And so I decided to shift my research efforts and focus to CPPD because it seemed like it was really ripe for exploration and there's a lot of patient need.
Yeah, I mean, it only took us 53 episodes to get to CPPD from this podcast, right? And I think that reflects a lot about certainly the lack of interest. But as you mentioned, it's much more common than we feel that it is, right? I believe I read that it's one of the top 3 causes of inflammatory arthritis. So I guess CPPD is a difficult term to define. I think it includes several different diseases. Can you tell us a little bit more about how you see what's the CPPD umbrella includes?
Sure, definitely. I mean, this has been something that I've learned a lot about in the past, let's say 5 years. So the term CPPD, first of all, what is the C, the P, and the D? C is calcium, P is phosphate, P is for pyro, and then the D is deposition. So CPPD that's the deposition of these calcium pyrophosphate crystals. Now, there's a word disease that would come after it that would characterize symptomatic features of having the deposition. So it's important because the term of CPPD actually can include asymptomatic deposition. That's somebody who has chondrocalcinosis, let's say, in their knee, and it's incidentally identified. But we think about this as really the arthritis disease when there are symptoms. And so the symptoms can fall into either inflammatory symptoms or non-inflammatory symptoms. Inflammatory symptoms I most commonly recognize as what we typically call pseudogout. EULAR had some proposed terminology about a decade ago that would rephrase pseudogout as acute calcium pyrophosphate arthritis. It's a mouthful. And then there's also a chronic inflammatory CPP arthritis that is historically been called pseudo-rheumatoid arthritis, and we can talk more about that. It tends to affect the MCP joints in particular. And then there's this other entity, which is osteoarthritis with calcium pyrophosphate deposition. And that one I'd say is the most loosely defined in my mind. This is including patients who have osteoarthritis in typical joints like the knee, and they also have chondrocalcinosis, but it also includes people who have osteoarthritis in different joints that are not typical for primary OA, like the shoulder or the radiocarpal joint. And there are also certain radiographic features of the OA that may be different from primary OA. So for example, OA with CPPD can be characterized by very large subchondral cysts. It occurs in these unusual locations sometimes. It also can be associated with certain patterns of joint space narrowing. For example, if you look at the patellofemoral joint, it's specifically the lateral patellofemoral joint that can be very narrowed. There really isn't enough research into this entity, in my opinion, in terms of are there different prognostic factors for people who have OA with CPPD with these particular types of bone findings. There have been some research studies looking at the presence of baseline chondrocalcinosis, let's say in the knee, and then the future progression of OA on MRI or the likelihood to have joint replacement. And results have varied between different cohorts. Some cohort studies have found that there's no impact of baseline chondrocalcinosis on the progression of OA. And some studies have found that there may be an increased pain score over time. So far, it hasn't looked like there's a dramatic impact of having chondrocalcinosis on progression of OA. But I think there's these different OA probably subtypes that exist.
It's so complicated. And I think I've learned that, maybe the CPPD is accelerating the OA, or maybe it's the other way around.
I think it's really unclear. Yeah.
Yeah. And I think that it's also very challenging treating these patients. I've certainly had patients with sort of early onset osteoarthritis that appear to have CPPD on these various joints. And the question is what to do with them. Do you treat them at all or just treat them as OA?
I mean, I think those are great questions. So when EULAR developed these terminology recommendations for CPPD about a decade ago, they also proposed some treatment recommendations. And the treatment recommendation for OA with CPPD was just treat as OA. So nothing different. While I'm just talking about these three different phenotypes, there is a Venn diagram between them for sure. If you look up some of the OMERACT CPPD working group publications, we have actually published a Venn diagram. So it's very much part of the concept of this disease is that people can have one or more of these manifestations over the course of their life. And the relative size of the circles with CPPD and the different manifestations is unclear. Probably OA with CPPD is the most common just because OA is so common. But I think in clinical experience, a lot of us have treated and seen patients who have the acute pseudogout phenotype. And I think a smaller portion is that chronic inflammatory phenotype.
Got it. Do you think CPPD, sort of the big umbrella term, is underdiagnosed?
Definitely. Can I prove that? Not exactly, but there have been about maybe 4 or 5 publications in the past year or two that have been really interesting in different cohorts, internationally, looking at the course of people who have been diagnosed with seronegative rheumatoid arthritis and then looking at what happens to them over the next 10 years or so. And in each of these cohorts, it turns out that 15-20% of them are later diagnosed as having CPPD. And I think that gets at this, number one, the clinical overlap between some of the phenotypes and, let's say, rheumatoid arthritis or osteoarthritis. And then the fact that we don't have really great treatments for CPPD thus far. And so if you're presuming somebody has seronegative rheumatoid arthritis and you're giving them TNF inhibitor, methotrexate and whatnot, and they're not improving, well, maybe we need to reconsider that diagnosis, and CPPD is on the list that is a potential possibility.
So tell me a little bit about diagnosing CPPD. In my mind, it makes sense if you have a swollen joint and you put a needle in it and you get calcium pyrophosphate crystals, that makes the diagnosis of CPPD. But, there may be times where the joints may be difficult to reach, or they may be small, or, you may tap the joint and not find crystals and it's still CPPD. How do you recommend we go about diagnosing CPPD in patients?
Yeah, I agree with you that there is that nice comforting binding of the crystals, and that gives us all this confidence that generally that's a person who has CPPD. And when we don't have a joint aspiration, or when we have a joint aspirate that's been negative for the presence of CPP crystals, it gives us a little bit more pause. I think traditionally, X-ray has been used as a screening tool for chondrocalcinosis. So there's a couple of caveats there, though. One is that calcifications that are seen on an X-ray, there frequently are calcium pyrophosphate, but they can be basic calcium phosphate, which is hydroxyapatite, and so a different disease. But the location of the crystals is something that can differentiate sort of the pattern of appearance, and then the location within the specific joint structures could point more towards CPPD than BCP. The other important thing is that X-ray is actually not very sensitive for calcium pyrophosphate deposits. And so in a patient who is early on in the sequence of developing CPPD, even though we don't know that much about the natural history of it, there are people that are, of course, starting to form these crystal deposits. X-ray may not be very sensitive, and published estimates of the sensitivity when using the synovial fluid aspirate as the gold standard, they get the sensitivity to X-ray is something like 50 to 60 or 70%. So it's fairly low. That's impressively low. And so then the question is, so what else can we do to help improve diagnosis? And I'd say that musculoskeletal ultrasound is a really promising tool, and it's widely used in Europe. I think it's used with great success in Europe because there's so much more training in musculoskeletal ultrasound just in all the fellowship programs in Europe. And Georgios Philippou and his group in Italy have done a lot of work in this space. And he works with the OMERACT group. They've developed ultrasound definitions for CPP deposits. And so I think that in the hands of a trained ultrasonographer who knows what to look for, ultrasound is more sensitive, especially with the early deposition of CPP. And then CT is another tool that we can use. There aren't that many data published so far comparing conventional CT to dual energy CT. But I think that both of them have the ability or have the promise to identify these deposits. And the question is, does dual energy CT add that much more than conventional CT? I think that the jury is still out on that one.
And in both of these imaging modalities, can you distinguish urate crystals from the calcium pyrophosphate crystals?
Yeah, with using dual energy CT, you can certainly distinguish monosodium urate crystals from calcium pyrophosphate crystals. They have different chemical properties that leads to a different dual energy index, and software can accurately color code one versus the other. I think the question is a little bit more about differentiating the BCP crystals from the calcium pyrophosphate because they both have calcium. And so, again, I think with the right settings on the software, yes, they could be distinguished, but there needs to be more research into the settings and, the companies that make these machines.
And how about an ultrasound? Is it usually easy to distinguish uric acid?
Yeah. So with gout and ultrasound, there's this double contour sign that we see where the monosodium urate is layering on top of hyaline cartilage. But with CPP crystals, they are inside of the hyaline cartilage. And so as long as you're aware of where the interface should be, it is different. As we call it CPPD pseudo gout, this is called the pseudo double contour sign in CPPD. So the location of these deposits is different. It's not quite as linear as it would be for MSU. It's more stippled looking.
Fantastic. So who's at risk of developing CPPD? What are the risk factors?
Yeah, so we know that age is an important risk factor, and some of it is probably due to just age-related factors alone, but some of it is also due to repetitive joint trauma over time, right? So joint trauma in and of itself is a risk factor. People who have been runners or skiers or had some sort of major injury to the knee, for example, or repetitive use to the wrists, for example. And osteoarthritis is associated, but I think the question, as you mentioned before, is still with which is the chicken or the egg. The CPP crystals certainly cause mechanical damage to the cartilage, and there are also local inflammatory factors from these crystals that can damage cartilage. But then again, as we just mentioned, that cartilage damage itself is a risk for developing these crystals. And then there are the more rare metabolic factors that we learn about in medical school that have to do with either pyrophosphate metabolism or potentially calcium. So for example, primary hyperparathyroidism, hemochromatosis, Gittleman syndrome, hypomagnesemia, these things that are rare. There are also very rare familial forms of CPPD, and these are people that have onset in their 30s, let's say, very young. And those are associated with, there are two known genetic mutations. One is in the ANC gene, which deals with ATP flux across the chondrocyte membrane, and then the other is in the osteoprotegerin gene, which has to do with rank ligand.
So when you see a patient in clinic with either chondrocalcinosis and osteoarthritis or an episode of acute CPPD, do you usually try to evaluate for potential causes aside from age and trauma?
If it's their first episode, I don't. But if they've had recurrent episodes, then I do. We did a case control study that looked at about maybe 1,500 patients with acute pseudogout. So about 1,500 patients that had these an episode of pseudogout, and then we matched them to comparators that had not had an episode of pseudogout. And we also identified that chronic kidney disease was associated with having this, and so was the use of chemotherapy. But I think there's a lot of potentially confounding issues with both of those conditions.
I want to get back to one of the things that you mentioned, which is the seronegative rheumatoid arthritis. I think this is one of the things that certainly has confused me in the past, and I know that it confuses others as well. I used to see seronegative RA as like one entity. Oh, it's just RA, but without a rheumatoid factor at CCP. And now I realize, no, it's just this heterogeneous group that some of which may end up having lupus, and I guess some of which may end up having CPPD or pseudo-RA. Aside from not responding to traditional RA treatments, do you have any other tricks or ways of distinguishing these two groups of pseudo-RA versus RA?
I think a lot of the time looking at radiographs can be helpful, although there is no pathognomonic feature to say that this is chronic CPP inflammatory arthritis. And finding chondrocalcinosis in the MCP joints is fairly uncommon. There's not a whole lot of cartilage right there. And so if you're just using x-ray, as most of us do when we're getting hand films, probably not going to see it unless there's a very large burden. But plain radiographs can show us joint space narrowing at the second and third MCPs in particular, which is thought to be a little bit more specific for CPPD if it's just the second and third MCPs. So the joint space narrowing, and then hooked osteophytes, they can also be seen in hemochromatosis, but can be seen in CPPD. Also, the presence of large subchondral cysts would maybe be suggestive of CPPD. And then I think sometimes we also see if somebody has a huge burden of chondrocalcinosis at the triangular fibrocartilage complex in the wrist, sometimes we'll start thinking about it more. But there hasn't been great analysis of data to look at the presence of that large burden of chondrocalcinosis in the wrist. And does that relate to having chronic inflammatory CPP arthritis? I don't know.
Yeah, it's so challenging. And, it's 2023 and we still it's amazing how complex these diseases are, that we still have difficulties in diagnosing something that in theory should be simple. Because one, it's caused by sort of an autoimmune response, and while the other one is caused by, physical crystals that irritate the joint. Maybe having better classification criteria, may help us in this. Can you talk a little bit about the efforts that you've done to try to come up with standard classification criteria for CPPD, and discuss a little bit about why is this so important and how are you going about it?
Sure. Yeah, this has been a multi-year effort with many, many people involved across the world, and it's been exciting to be part of. We are very near culmination publication. So that's a good feel, well, hopefully in this year, hopefully very soon. So for any disease, when we're thinking about enrolling people into research studies, especially clinical trials, it's just so critical that we're enrolling people that have a fairly consistent presentation of disease so that we can compare across studies. And so that's what this effort was aiming to do, was to develop a set of criteria that would identify people that with good certainty have CPPD. It's not going to capture all people with CPPD because there needs to be some trade-off in general between sensitivity for detecting a disease and then being very specific for identifying the disease. So this effort involved adult rheumatologists, methodologists, and radiologists from across the world. We followed a 4-phase process that ACR and EULAR have endorsed for many other classification criteria, where we first started by identifying a lot of potential items that might be able to distinguish CPPD from other kinds of arthritis. And then using data and using expert opinion, we narrowed that list. And then we tested the relative importance of those items against one another, developed some framework for trying to classify CPPD, and then tested how that framework worked, functioned, and performed using an independently collected set of patient cases and mimickers. And so without too many spoilers, the final classification criteria, I think as one would expect, rely on largely feel very positively about having synovial fluid CPP crystals demonstrated, right? So that feature is really thought to be consistent with CPPD for research purposes. And then in the absence of having synovial fluid CPP crystals identified, a combination of clinical features and imaging features would be sufficient to classify a person as CPPD. Functionally, what it means is that if a person hasn't had a synovial fluid aspirate with CPP crystals, they need to have some sort of inflammatory arthritis in addition to imaging. If a person only has imaging features and they have osteoarthritis on imaging or clinically, but they haven't had inflammatory arthritis, then they wouldn't be classified unless they have had a synovial fluid aspirate with the crystals. And so I think for phase validity, to me, that makes sense. I think that that's also an interesting point of debate, where some people may feel that maybe a person who has osteoarthritis of the knee and they have chondrocalcinosis in lots of joints, like maybe that person should be classified as CPPD for a research trial that's trying to remove CPP crystals, for example. But I think the flip side is that we don't really still quite understand how does OA with CPPD differ from just OA.
So, Sarah, how close are we to having a CPPD classification criteria? And why do you think this is so important?
We are close after many years of effort. So that's very exciting.
We've had so many authors here that have discussed classification criteria or treatment recommendations, and it always takes a lot longer for them than they thought initially. How long have you been working on this project?
This actually has been fairly concise given that the pandemic happened in the middle of it. We started in 2019. I think we had a face-to-face meeting in 2019, and that was our only face-to-face meeting. Yeah, but then, we had the pandemic, and we moved to Zoom, which was actually quite useful given the international composition of the working group. So we've made great progress, and we had participation from many, many centers around the world, which is always exciting, and it also improves the generalizability of the criteria.
Awesome. So why are you working on this for so long? Why is it so important?
Well, as we've just been discussing, there is heterogeneity in the presentations of CPPD. And when we look to the literature that's tried to inform our understanding of what's the natural history of this disease and what are the consequences and possible treatments, the definition of CPPD has varied so much between studies that it's actually quite difficult to compare across studies. So, for example, some studies define this disease just by the presence of radiographic chondrocalcinosis without taking into regard the presence of symptoms. And I think that's problematic given what we discussed earlier, that CPPD as this umbrella term does include asymptomatic deposition, but we don't know who of people who have asymptomatic deposition, who's going to develop symptoms. We don't know. And so when we're thinking about, again, clinical trials, developing treatments, or understanding the long-term outcomes of people with CPPD, we're focusing on people who have symptomatic disease. And that's what the classification criteria are going to inform. So how do we identify a group of people that are relatively homogeneous so that they could be compared across studies? And so in essence, what the classification criteria ask the person who's applying them to do is first to ensure that a person has ever had joint symptoms, then to make sure that the joint symptoms are not fully explained by something else. For example, if the doctor treating this patient thinks that all of their symptoms are just due to osteoarthritis and they don't think there's any contribution of CPPD as well, then they just don't get considered for classification. Or if they had septic arthritis and they had joint inflammation and that was thought to explain the whole thing, you just don't try to classify them. But then if there is the possibility that CPPD is part of the symptoms, then we can continue to try to classify them. And in essence, if a person has had a synovial fluid aspirate that has calcium pyrophosphate crystals from a symptomatic joint, then they're classified. So that feature is thought to be very, very specific for CPPD. And then if a person hasn't had synovial fluid aspirate with the crystals observed, or even if they could have had a synovial fluid aspirate, but it was negative for the crystals, then we can try to classify them with a combination of clinical features and imaging features. And imaging features are weighted quite highly, but in essence, to be classified, you must have some clinical symptoms of joint inflammation in addition to imaging, unless you've had this synovial fluid aspirate with CPP crystals. And so in essence, it means that if somebody has osteoarthritis, they have chondrocalcinosis in 8 joints in their body, that's actually not going to be sufficient for classification unless they've had synovial fluid aspirate with CPP crystals. And I think this is something that is maybe provocative. I'm curious to see what the response will be once the criteria are published. I'm discussing right now provisional criteria. They haven't been fully approved. So with that caveat, I think that for a clinical trial, if we're looking at therapies to try to reduce symptoms of, let's say, chronic CPP inflammatory arthritis, we're definitely going to want joint inflammation as a component. But I think that there's also potential for looking at therapies that look at people with OA and CPPD. And so, again, people to be classified by these criteria, they would have had to have some signs of joint inflammation at some point.
That makes a lot of sense. So you sort of alluded to treatment. Shifting gears a little bit, how do you treat acute CPPD or pseudogout?
Yeah, I think that there are different ways we can treat it. And these are generally older patients. They have comorbidities, and so those need to come into mind too. But I think that the most common way that we treat acute pseudogout is with steroids. It's typically a short course of oral steroids. The starting dose is going to vary from clinician to clinician. Again, these are generally older people in their 70s, 60s, 70s, 80s. And so I personally tend to start with a fairly low dose, what I consider fairly low dose of prednisone, something like 10 milligrams for 5 days. And then if they're not improving in 2 days, I ask them to call me, and then we can increase the dose a little bit. But I tend to be more conservative with the steroid dose. There was, at the ACR meeting in 2022, Tristan Pascart presented results from a randomized trial in acute pseudogout, which was amazing that he performed this trial, which is in France. It had about 120 patients.
Wow.
Yeah, they were randomized to either prednisone 30 milligrams for 2 days or colchicine with dosing that's similar to what we would use for acute gout. But it was in Europe. I forget if it was 1.0 or 1.2 milligrams, and then followed by the one pill an hour later. And then like the next day they got another pill. They only treated for 2 days for acute pseudogout. And they also, importantly, they gave a fair dose of acetaminophen and tramadol to all of the people in the trial. And these were hospitalized patients with pseudogout. My main question was like, how much delirium occurred? Because these are older people in the hospital and they did not report a lot of delirium. So for what it's worth, it seemed like the people in their trial tolerated those medications fairly well. And the two treatments, the prednisone and the colchicine, had very similar reductions in the pain VAS at 6 days was their primary outcome time. But they also did allow the investigators to prescribe at their own discretion after day 2. So for example, if someone was still having pain after day 2 of prednisone, they could get some more prednisone or they could get some colchicine. So it wasn't as strict of a protocol. I think what I took away from that trial was that at least 2 days of each of these therapies were relatively well tolerated. There was more diarrhea in the colchicine group than in the prednisone group, but it wasn't a very large percentage. It was maybe like 15 or 20% had diarrhea. So I think that colchicine could be a good option for people who are hospitalized, who are older, if they have, pretty normal renal function. And then there's also the question of like anakinra, I think always comes up in the hospital setting when people have lots of comorbidities, if they have an active infection or they have heart failure. And, there's questions about giving them steroids and worsening fluid overload, for example.
Okay. So I guess, it sounds pretty similar to how we would treat acute gout with colchicine, prednisone, maybe some IL-1 inhibition.
Yeah. Maybe inject the joint also if it's just one joint involved and if it's a large enough joint.
Fantastic. And then what about the pseudo-RA patients? I think those are, in my mind, a lot more challenging to treat.
I agree.
I would love to hear your insights into treating that process.
Sure. And I think that a lot of the patients who have that pseudo-RA phenotype have been treated for RA or it's on the differential if they're early in their course. And so I will generally start colchicine in these people just because if it works, right? It's kind of low-hanging fruit. It doesn't need to be monitored quite as much, although with long-term use it does. So I would try that maybe just even once a day. And again, it depends on their renal function. And then I think the next two options that I discuss with patients are hydroxychloroquine and methotrexate. There was one randomized trial of hydroxychloroquine. It was published in the late 1990s. It's actually very difficult to find this paper. I had to inquire to several libraries to actually get the paper, but I got it. And they treated patients with hydroxychloroquine 400 milligrams maximum daily. So that's pretty consistent with 5 milligrams per kilogram. And they didn't follow them for an incredibly long time. It was 6 months, but that's pretty fair amount of time. And they found that joint pain was reduced in the hydroxychloroquine. And this was a crossover trial. So in the hydroxychloroquine time periods, there was less pain, or like the percentage of people that had, I think it was a tender joint count of it was a 30% reduction in tender joint count is what it was significantly greater in the hydroxychloroquine group than in the placebo group or in the time periods on placebo. So there's that one study. And I think, again, hydroxychloroquine is generally well tolerated, right? It doesn't need a tremendous amount of monitoring. For these patients, I might say we can even wait to get your baseline eye exam. And so let's see how you do after 3 months. And then if it doesn't work, then I would also try methotrexate again with the caveats of older people and renal function. There are not great data for methotrexate in CPPD, but there was one trial that tested this, and the maximum dose of methotrexate they used was only about 15 milligrams weekly. So I would try to get them up to 25 milligrams weekly if they can tolerate it. Again, And then if those don't work, or their symptoms are just so inflammatory and you don't feel like you can wait that long, there's two other possibilities. One is anakinra. And again, this is if these people have the thought of seronegative RA, well, then anakinra is approved for RA. So you can try it.
Brilliant.
Yes. And the other that's worth considering, again, with the thought about kind of this question of RA, is tocilizumab. There was an open label pilot study in France also it had just about 10 people that had either recurrent episodes of pseudogout or they had chronic inflammatory CPP arthritis. And the results were mixed. Seemed like most people had some benefit, but not all people. So it's just something else to think about in the armamentarium.
Wow. I'm surprised by the lack of research into various treatment options. Do you know of any other research studies that are currently ongoing that may be testing novel therapeutics for CPPD? Or are they all waiting for your classification?
Yeah. I think the classification criteria are going to be helpful. To be totally frank, I've tried to engage with a number of pharmaceutical companies to understand interest, and it's been spotty to low. So I'm also part of the OMRAC CPPD working group where so in parallel with, so the ACR and EULAR are sponsoring the classification criteria development. So that'll help us understand who to enroll in a study. But then the next question is, what do we measure in a clinical trial? So OMRAC is trying to define that. And that's been going on since 2018. Again, very long process with the pandemic in the middle. And so we're almost there as well. It's possible that later this year we'll have developed this core set of outcome domains to be measured in CPPD clinical trials. So then there would be those two components to sort of the framework for research. But as the OMRAC group was developing this core domain set, we tried to engage with a variety of stakeholders that helps to improve sort of the validity of the process. So we have clinicians, investigators, patients with CPPD, and then we also tried to engage with arthritis foundations and pharmaceutical companies. And when I approached a number of pharmaceutical companies in the US, the response was either, we're not interested in CPPD, we don't know what CPPD is, that's just not really on our agenda, even for some companies that make treatments that I've just mentioned. So they're just it's not their focus. And so recently I've been trying to establish, and I think I have established, a relationship with the Arthritis Foundation in the US to try to create some patient education initiatives. And maybe that'll help with some grassroots efforts to try to get more interest in developing therapies for CPPD, because I think patients really identify a need for this. We identified that. We have a CPPD cohort at Brigham and Women's Hospital. And at the ACR meeting, we presented some research that compared patient-reported outcome measures in CPPD patients in our cohort against published gout and OA cohorts that had answered similar questions. And so they're using the same scale, but just changing the word from gout to CPPD. And so when asked about the treatment need, there was a significantly greater unmet treatment need in people with CPPD compared to people with gout. This was in a historical cohort from 10 years ago. Yeah.
Wow. So, I mean, I'm just awestruck by the fact that, CPPD, there's millions of people with CPPD in the United States and a lack of pharmaceutical companies trying to go after that market.
Yeah, I'm trying to drum up interest. I think there's also these different subsets. I think the people who have the chronic inflammatory arthritis, they probably have the greatest need because they are having chronic symptoms and they're not responding to other typical therapies.
Yeah. So any pharmaceutical companies out there, please contact Sarah for potential research studies. So what do you see as the future of CPPD? I mean, it sounds so exciting what you've been working on. We're going to have classification criteria to enter people into trials. We're going to have the OMRAC criteria to be able to sort of measure the things that matter in clinical trials. So what's next?
Well, I think until there's enough momentum, and again, I think that pharmaceutical companies would be one part of it. I think that the NIH is another part of it. And so again, to all those NIH reviewers listening, they have put in a grant application that may be focusing on some of this. And so I think that, hopefully there's going to be more interest from investigators around the country who want to develop their own CPPD cohorts and internationally. Again, we need cohorts of patients that are engaged and that are ready to give us their perspective on how this disease is affecting them so that we know what we should be studying. Again, providing a pool of patients who might be interested in participating in clinical trials when therapeutics are available to be tested. And then I think the other thing that we can do in the meanwhile, while that is incubating, is also to understand more about the natural history of this disease, the different phenotypes, and the long-term outcomes of this disease that are outside of the joint. So when we think about rheumatoid arthritis, psoriatic arthritis, gout, we don't just think about the joint. We think about their cardiovascular system. We think about their lungs. We think about other parts of the body that might be affected by inflammation, or in this case, maybe by crystals or something sort of damage that's related to having this inflammation. So we were able to perform a cohort study that was using patients that had acute pseudogout, matched to comparators, and we looked at the risk of having an incident cardiovascular event after they had that episode of acute CPP arthritis or acute pseudogout. And we identified a significantly higher risk. And this was in 2 different cohorts. One was in a veterans cohort nationwide. It had 23,000 veterans. That was with a broader definition of CPPD. It didn't have to be acute pseudogout. With 23,000 veterans with CPPD matched to about 4 comparators each. And there was a 25% increased risk of a non-fatal cardiac event in people who had CPPD. So then we did a similar study using Mass General Brigham electronic health record data for people that had acute pseudogout. And we found about a 2-fold increased risk of having a non-fatal cardiovascular event in the next 0 to 10 years later. Now the question is why, right? So is it something to do with inflammation? Is it something to do with calcification? I think there are a lot of interesting questions that can be answered.
Yeah, fantastic. We started out this program talking about how CPPD is not a very popular topic, but your excitement certainly excites me about it. And now I want to start, seeing those patients and hopefully referring them at one point to clinical trials that you may be running in the future. This has been a great conversation, Sarah. I really appreciate your time. And thank you so much for all the work that you've been doing for patients with CPPD, and certainly for your teams and OMERACT and the team developing the classification criteria. I think it's 2023. These things probably should have been developed a while ago, but I'm glad that you're looking to finish them this year.
It's been wonderful to engage with such a great international team of clinicians and investigators that have been interested in CPPD and have developed a really nice number of working relationships with people across the country and across the globe.
Well, keep up the good work, Sarah.
Thanks so much for having me.
Well, I hope this episode answered all your questions about CPPD. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show and notes for this episode at acronair.org, and also on Apple Podcast, Google Podcast, Spotify, and on your favorite podcast app. Until next time, keep fighting those crystals, and of course, stay healthy.